2009. So we hope to promote the health and well-being of South Asian communities in the United States through advocacy, collaboration, and communication. And these are some of our goals: to advocate, foster, and communicate. Thanks. Go ahead. These are our intentions and agreements for today's workshop. So we'll try to our best to be present whilst being responsive to our own needs. We will respect people's pronouns and be mindful of our own assumptions of their identities. The focus for today is to center learning, curiosity, and growth. This is a judgment-free space, and to engage in whatever way feels most comfortable for us. And each kind of, we'll have polls throughout, so each of them is an invitation. And you can participate or not participate, whatever you want. This is just our land and labor acknowledgement. I'm not going to go through the whole thing, but we just acknowledge the undervalued and underappreciated forced labor by those of African descent that built the land that we stand on today. We also recognize that the land we stand on has been stolen, and our commitment is to help dismantle the ongoing legacies of colonialism as well as other systems of oppression within our society. Go ahead. Thank you. Oh, sorry. So just to introduce our speaker for today, Dr. Sohni Pathan. She is a second-year OBGYN resident who's currently training in Fort Lauderdale, Florida. And her research and practice interests include minimally invasive surgery, endometriosis, epigenetics, and nutrition. Outside of medicine, Dr. Pathan is also an amateur restaurant critic, a ClassPass enthusiast, and the proud new owner of a kitten named Ella. Thank you, Sohni. Go ahead. And we're very excited for your presentation today.
All right. Thank you, everyone. Thanks for joining us today. I'm very excited to be here. Once again, just to introduce myself, my name is Sohni Pathan. I am a second-year OBGYN resident down here in Fort Lauderdale. Some of the connections I do have, Nawal, who is part of this meeting as well, someone I know from college, and I'm originally from Texas, but I'm a transplant down here for schooling and work purposes. In any case, I'm very excited to be here and present to you on this topic. Part of the reason I went into obstetrics and gynecology was because I knew of all the taboos and myths that were affiliated with the South Asian community and that we were kind of inculcated in growing up. And I was hoping to be part of that change to kind of break those myths. Is everyone able to see my screen?
Yeah, just one thing, Sohni, there's Fatma's like face, well, not my face, is like a little bit picked up the screen in case you wanted to.
There we go.
Yeah.
Perfect. Alrighty, so some of the credentials and disclosures, as I said, I am affiliated with HCA Florida Westside Northwest as my OBGYN program. However, any opinions that are shared today are not directly affiliated with HCA, and I have no other disclosures. So we'll go over an overview of what this presentation will entail. The first thing we'll kind of discuss or go over is the language and the statistics involved in this subject. We'll briefly do a layman's science and anatomy lesson just to understand the basics of birth control and oral contraceptives. We'll discuss some of the indications, some of the methods of contraception. We'll do a little Mythbuster special edition, which will involve the polling and the interactive portion of the program today. And then we'll briefly discuss some of the implications in South Asian communities, both from a provider as well as a patient perspective. At the end, I have included some resources that are available to the public, whether you're a patient or a provider, and then there will be references and time for a Q&A and closing remarks. So just a brief overview of the language. Birth control, contraception often are interchangeable. Birth control would have a little bit of a more political, emotional connotation to it. So for the sake of this program, we will stick to using contraception. It's the most broad category of medications or devices used to prevent pregnancy for those who desire it, which may include both hormonal and non-hormonal methods, such as implants, pills, spermicide, barrier contraception, etc. You may have colloquially heard of the pill, which most commonly refers to combined hormonal oral contraceptive pills. however, may colloquially be interchanged with the mini pill, which is a progestin-only pill, which is a singular form of hormonal birth control, which we will discuss a little bit further, that there are several different types. So just a brief chat about the data. So there are a few studies elucidating opinions about contraceptive use among South Asians. However, I would say that definitely more research could be done. This first paper was completed by Ms. Nandini Shroff regarding contraceptive use among South Asians in New York City, reporting that approximately 67% of South Asian Americans use contraception at their last sexual encounter. However, compared to South Asians, other Asian Americans showed higher likelihood of using contraception that may be associated with cultural barriers, knowledge gaps, etc., regarding contraception. Another cross-sectional study was done with approximately 42 South Asians, 143 non-South Asians, showing that South Asians were significantly less likely to routinely use contraception. And again, they did describe common barriers, including family opposition, pressure from spouses, in-laws, cultural prohibitions, and fear of adverse effects. Something to mention regarding both of these studies and a few of the other studies that were seen on my brief literature review. A lot of these were considered retrospective, meaning that they're looking at data from the past. However, there is no like prospective data, meaning looking forward, that can really elucidate these findings. And additionally, they're relatively smaller sample sizes, so definitely need more work in this field. So now we'll briefly transition to the anatomy. I like to kind of go over this so you generally know what's going on and where we are at. So the main organs we'll be focused on will be the uterus, the fallopian tubes, the ovaries, and then even the cervix as well. So we'll do an introduction to reproductive physiology. Things can get really nebulous here, but this diagram kind of breaks everything down as appropriately as it can. There's several levels as to what's happening during a basic menstrual cycle. So the first portion is what happens up in the brain, in the hypothalamus and the pituitary gland, which produce the follicle stimulating hormone as well as the luteinizing hormone. And then we are also at the level of the ovary, which you can see down here. At the ovarian level, we're producing estrogen and progesterone as part of your menstrual cycle. In addition, you are producing a dominant follicle and you're ovulating a single egg every month and producing a corpus luteum if you do end up having a fertilized egg, meaning you are proceeding with pregnancy. The corpus luteum helps support the pregnancy by producing hormone and continues to allow the pregnancy to grow, and it allows the endometrium to support that pregnancy as well. So we'll first start with the follicular phase. The follicular phase is defined as the first 14 days of the cycle, starting from day 1 of your menstrual period, meaning the day 1 of your bleeding, all the way to day 14, which is just prior to ovulation. There's a few dominant hormones because we're working at 2 levels here. So we're working at both the pituitary, meaning the brain level, as well as the ovarian level. So at the brain level, day 1 through 8, follicle stimulating hormone and luteinizing hormone are elevated, and they're causing a stimulation for the production of several of these follicles. So all these follicles that you see here are what are being stimulated here in the ovary in order to create a dominant follicle, which occurs between days 9 through 14 with the help of estrogen. It helps the maturation of that dominant follicle, and the end goal is that this dominant follicle will ovulate on day 14. Ovulation itself is characterized by a surge in this luteinizing hormone. You may have generally heard of a LH surge. Oftentimes, if you're someone who's used ovulation kits, that's typically what it is testing for. So the LH surge is what characterizes ovulation and allows for several cellular processes to burst that dominant follicle and lead to the egg being ovulated and into your fallopian tubes. The second phase of your menstrual cycle is your luteal phase. So that's typically between day 14 through 28. The dominant hormone at this portion is progesterone. The end goal of this is to prepare the endometrium and form the corpus luteum to continue to promote the pregnancy. So initially in your cycle, like I said, estrogen helps your follicles mature. It does also proliferate, meaning grow your endometrium. And then the progesterone later on in your cycle just helps some of those blood vessels get nice and juicy and continue to promote the pregnancy if that is what ends up happening. So this is basically how hormonal contraceptives work. Now that we've looked at the different levels of the menstrual cycle, as well as what occurs at the different areas, we can talk about what progestins and estrogens do. So as you can see here, like I said, estrogen and progesterone are what are produced by the ovaries in order to maintain an appropriate cycle. Progestins are a class of oral contraceptives, a hormonal contraceptive. You can basically think if you're supplementing progesterone at any phase here during the cycle, your body is thinking that it has enough progesterone, so it is not going to produce the luteinizing hormone and the follicle stimulating hormone. It's going to suppress the LH secretion. This is at the brain level that it does that, and thus it inhibits ovulation because that luteinizing hormone is what's needed for the LH surge and the ovulation. Estrogen at this level suppresses the follicle stimulating hormone, which prevents the formation of the dominant follicle down here. If you remember, as we work backwards, estrogen helped make the dominant follicle, so that's no longer happening. In addition, estrogen is also used to generally stabilize the endometrium, and it reduces irregular shedding. This is something that a lot of OBGYNs may play with as far as dosing to help with irregular bleeding, breakthrough bleeding, or heavy menstrual cycles in general. In addition, progestins do work at the level of your cervical mucus. It thickens the cervical mucus, making the cervix impenetrable to sperm. So as you can see here, around this time at ovulation is when your cervical mucus is the most watery and penetrable to sperm. However, when progesterone takes over naturally here, it's thick again. And so that's what progestins help simulate. So I wanted to talk about some of the non-contraceptive uses for contraception because it is a medical treatment for a lot of disorders. So it can be used to treat premenstrual syndrome, premenstrual dysphoric disorder. It can be used to treat endometriosis, polycystic ovarian syndrome or PCOS, endometrial hyperplasia. It can additionally be used to treat endometrial intraepithelial neoplasia, which is a precursor to a cancerous lesion of the uterus. It can be used to treat heavy menstrual bleeding, and it can simply be something that patients use for desire for amenorrhea or gender-affirming care. So some of the pathways in which it helps treat some of these illnesses and diseases, one thing to mention is the sex hormone binding globulin. So typically, progestins and estrogen together, meaning a combined hormonal contraceptive, help increase sex hormone binding globulin. Sex hormone binding globulin is produced in the liver. It helps bind any excess testosterone in your body, and it decreases hair on your face, which is otherwise known as hirsutism, acne, and it may also improve insulin sensitivity. So a lot of patients who have PCOS or signs of what we call hyperandrogenism, which is acne, hirsutism, hair on your face, weight gain, can be effectively treated with hormonal contraceptives in conjunction with other treatments as well. In addition, there are several different types of progestin classes. Also good to mention because some are more anti-androgenic, and anything anti-androgenic is essentially anything that's anti-testosterone, helps bind the testosterone, or it works in ways to decrease your natural levels of testosterone. Also used to treat acne, hirsutism, premenstrual disorder, and premenstrual dysphoric disorder, which are all associated with some sort of issue with androgen metabolism. So that's something to consider as far as discussions with your provider if you are interested in being on some sort of contraceptive for treatment of other diseases. So now we'll transition over to going over the general methods of contraception. I'll try to be as comprehensive but as brief as possible. This diagram was probably the best diagram I could find. It's from the American Academy of Family Physicians. They provide several guidelines as far as family practice physicians, and preventive care, which contraception is definitely a portion of that. So this really helps kind of elucidate what each method does, the failure rates, which you'll see down here. Which basically in science terms is referring to in 1 year the risk of pregnancy / failure of the device. So we'll initially start up here at the etonogestrel arm implant. You may have heard of this. It's called Nexplanon. It's typically inserted in office with an applicator. The hormone that is in that it's called etonogestrel, which is a type of progestin. The main mechanism of action, as we've discussed before, which you'll continue to see this MOA abbreviation, its mechanism of action, prevents ovulation, and the length of use with this arm implant is 3 years. As far as the IUD, there are 2 different types of the IUD. There's the hormonal IUD as well as a non-hormonal IUD. The hormonal IUD is called levonorgestrel. You may have heard of it as Mirena, Liletta, Skyla. Those all really depend on the amount of levonorgestrel on the actual IUD. And that length of use where you see is cited as up to 8 years, I say because depending on the dosing of the levonorgestrel, you may have the IUD in for up to 8 years. For example, the Mirena IUD has the highest dose of the levonorgestrel on it, so that can stay in for 8 years. The main mechanism of action for this is that it thickens cervical mucus, and it additionally provides a spermicidal effect in the uterus by causing a low-grade sterile inflammatory response. This does not prevent ovulation. Some patients colloquially feel that ovulation is important to them, and they find that the levonorgestrel IUD is something that can support that for themselves. Whereas the copper IUD, again, has no hormone on it. The main mechanism of action here is that it provides a spermicidal inflammatory response in your uterus, and this can be used for up to 10 years. The main things to consider with that copper IUD is that it may cause heavier menstrual bleeding. So if you're a patient who already has heavy menstrual cycles, or you're simply desiring not having menstrual cycles at all, then it'd be something to consider to try maybe the levonorgestrel IUD instead. These have some of the best, meaning the lowest failure rates. The arm implant has a 0.05% failure rate. The IUD, the levonorgestrel IUD, has a 0.2% failure rate, and the copper IUD has a 0.8% failure rate. So very, very low. And these are what we call reversible methods of contraception. So now we'll move forward to the permanent levels of permanent methods of contraception, which include the male sterilization as well as the female. The male partner sterilization is typically an in-office procedure. It's very short, usually done under sedation, and is generally low risk. Female sterilization is also another option, typically done in the operating room via surgery. Usually the tubes of the fallopian tubes are removed. Both of these are extremely effective. However, it is very important to counsel patients appropriately that these are generally considered to be permanent. You may have heard of reversal of vasectomies or patients getting pregnant after female sterilization. However, it's just very important to consider that it's considered a permanent sterilization option, and they may have to consider assisted reproductive technology if patients are interested in having future fertility, meaning IVF. The next few methods of contraception we'll kind of go over are the ones that are maybe a slightly less effective, but still good options, dependable as well. The first one will be the injectable depo-medroxyprogesterone acetate, also known as Depo-Provera. The main hormone in this is progestin. The mechanism of action here is that it prevents ovulation. It also thickens your cervical mucus. And the main thing to consider here is that the length of use is typically 3 years at a time, with a recommendation for some break intervals due to a concern for reversible bone loss. So just the Depo-Provera is associated with this side effect of bone loss in patients who've been using it for extended periods of time. However, even with stopping it and taking a break and trying another method, that bone loss ends up, your bone ends up regenerating. So it's something to consider. 6% failure rate, and every 3 months, this Depo-Provera needs to be injected again as well to maintain the efficacy of the medication. The next one we'll discuss is the ubiquitous pill that everyone's heard of, the oral contraceptive pill. Typically, the hormone in this is a combined contraceptive, meaning it has some form of estrogen, which is typically ethinyl estradiol, and some form of a progestin, which can be, there are several different classes and of progestins, as I had mentioned earlier, that are kind of catered patient by patient. In addition, there's also progestin-only pills, which have no estrogen in them for patients who may potentially have risks associated with estrogen use or health history that may prevent them from using estrogen. Main mechanism of action here, as I had mentioned earlier, it prevents ovulation, it thickens the cervical mucus, and the oral contraceptive pill is something that may be used for unlimited periods of time. Of course, it's something to consider. There is a 1-week placebo with the pill. So it's 3 weeks of a hormonal pill and then a 1 week of essentially a sugar pill that allows for a withdrawal bleed. That helps patients kind of continue to time their cycles and ensure that the hormone is producing a bleed appropriately. Some patients don't want to have the bleed and they may have a continuous pill pack, meaning they just go straight forward because they have a history of heavy bleeding, and that's also an option for them. The next method we'll talk about is the patch. I don't see it often personally, but the patients who I do prescribe this to are usually long-term users and they love it. It's a combined hormonal patch that's typically attached to the arm or the lower abdomen. The main mechanism of action here is that it prevents ovulation. The length of use here, so the way you use this is you place it on skin once a week for 3 weeks, and then the last week will be the withdrawal bleed week where you have like a hormone-free week, essentially. A lot of patients really like this. There is concern with the patch that there haven't been good studies done on patients with higher body mass indexes. So this may be something that's limited to patients either who have good experience with it or under certain BMIs. However, there's only a few studies that mention that there's a risk with using the patch in higher BMIs, but there haven't been anything like too conclusive. It's more of a provider preference more than anything. Okay, and then we'll discuss the ring. You may have heard of the Nuva ring. You may have seen commercials online or on TV for it. This is another combined contraceptive. These are essentially local, so it's hormonal contraceptive. It's a hormonal ring that is inserted vaginally every 4 weeks or so, and does not need to be removed at the time of intercourse, and it also prevents ovulation. Again, length of use of this is typically 3 weeks, and then it's removed at the 4th week to have a withdrawal bleed, and then it's reinserted after that portion. The diaphragm that you see here at the end of this row, I'll discuss later with the spermicide because oftentimes they are used together. Alrighty, so we'll go over some of the less effective but still important methods of contraception. We'll speak about the barrier methods. So there's no hormone involved in any of these methods. The main mechanism of action here is that it blocks sperm from entering into the cervix. These are all single use. Main thing to consider here is that male and female condoms, but more particularly male condoms, are the only form of contraception that can potentially prevent sexually transmitted infections. So that's something to consider. And then with perfect use, it's an 18% failure rate. Withdrawal is a very common old method of contraception. There's no hormone involved. The main mechanism is withdrawal of the penis prior to ejaculation during intercourse. The main drawback that a lot of patients and providers are concerned with is that pre-ejaculate fluid may have sperm in it, which leads to that high failure rate that you see here. It's a 22% failure rate that you see in a year. However, there are studies that show with continued withdrawal at every encounter for intercourse, you may have a 4% failure rate, which puts you at a failure rate that's quite similar to that Depo-Provera that you see up there. So it can actually be pretty effective, especially if you're using it in conjunction with any of the other methods. That isn't to say, it's the best method out here, but if a patient is not interested in being on any sort of hormonal birth control, it is an option for them. The sponge is another one that we'll briefly go over right now. I personally don't have a lot of experience with it, but it is always an option. Most providers these days aren't prescribing it anymore, but it's basically a little sponge that is inserted vaginally at the time of intercourse, and it's associated with a 12% failure rate with patients who have never been pregnant before and a 24% failure rate with patients who have been pregnant before. So that's something to consider as well. I wanted to briefly discuss the spermicide and the diaphragm, which, like I said, they're typically used together. The spermicide is sometimes placed in the diaphragm, and the diaphragm is placed vaginally over the cervix. Again, non-hormonal method of contraception, and it can be used together. The main mechanism of action here is that it blocks sperm and also kills the sperm. Something to consider with these methods is that they may cause some vaginal irritation. However, there has not been any long-term adverse effects affiliated with any of them. And then the last method we'll discuss is fertility awareness and cycle tracking, which is another tested and true old method of contraception. It really depends on the patient as far as how they want to proceed with fertility awareness tracking. So this may include monitoring home levels of LH, as I mentioned, to track ovulation as well as menses. Some patients like to do basal body temperature method, which involves checking your body temperature every day, first thing in the morning, and making a log. Typically, you see a 0.4 to 0.8 degree Fahrenheit rise in temperature during ovulation, and that's how they time intercourse. And then another option is also cervical mucus testing. So that involves kind of tactile feeling that cervical mucus is thinning and becoming more watery, and timing intercourse based on that. These are very beneficial methods, especially for patients who have regular cycles. Of course, that's not the case for a lot of patients, especially ones who are seeking contraception for non-birth control use. But it is something to consider, especially for patients who don't want to be on any form of hormonal birth control, or if they're patients who are generally compliant and are good with tracking their cycles. All right, so now it's going to be time for our interactive portion. So we'll do some of these true or false questions. I'm not sure exactly how y'all want to proceed with it. I know there's a poll in the chat. And we'll go over some of these true or false questions, and then I'll give everyone a couple of minutes to answer, and we'll kind of we'll debrief after each one. So the first one, true or false, contraception can cause long-term infertility. And I think because I'm logged in on the screen, I can't see the polling. So
I can tell you from the chat, it's saying 90% of people are saying false so far, 82%, 17% are saying true.
So, Sohni, all of the questions are actually visible, so maybe we can give people like a minute, and then
great.
And because people are actually responding, and then once we end the poll, you can still go through your answers for each one on their slides.
Okay.
Yeah.
Perfect. Alrighty, so I'm just gonna go over to the next slide then. So this is actually false. It does not cause long-term infertility. So Dr. Giram et al., he had a study that it was a sweeping review of thousands of patients that reported that while return of fertility may vary, there's no evidence suggesting long-term effects on fertility itself. So this may be associated with reasons that contraception is used. As I said, it could be used for PCOS, endometriosis, which are known to have issues with ovulation, in which there may be a long-term, or not a long-term, a longer return to fertility. However, there is no perceived long-term effect. Typically, patients within the first year after stopping any sort of contraceptive option, there's an 84% pregnancy rate. All right, next one, contraception is associated with cancer.
So we have people who 11% answered true, 89% answered false.
All righty. So this one's actually true, but it really depends on your individual risk, and we'll kind of go over the different cancers that are implicated with contraceptive use, because it's super important. This is definitely something that's gained a lot of traction recently on the media. So we'll discuss this briefly. So we'll talk about breast cancer risk first. There actually is an increased risk of breast cancer with current/recent use of combined hormonal contraceptives. However, there is no increase with longer duration of use. In addition, if you are a BRCA1, BRCA2 carrier, meaning those are the genetic predisposition for breast cancers, you already have an increased baseline risk. However, contraception does not increase that risk. It does not increase that baseline risk. However, it is extremely important to talk about family history with your doctor as far as proceeding with contraception, because if you have any history of breast cancer, automatically you cannot use a combined hormonal pill. Regarding ovarian cancer, birth control is actually considered protective against ovarian cancer. The best way I can think of this is you can think of anything that's like a moving part. The more it moves, the more chances of it to have a failure. The more often that you ovulate in a lifetime, the more likely of a risk there is for these cells to continue to divide and cause cancer. Patients generally, so you and me on the street, 1.6% risk of ovarian cancer. If you are decreasing your ovulation by not having or by being on a contraceptive option, you are decreasing your risk of ovarian cancer. So it is reduced by 40% compared with that of non-users, and that's probably the biggest protective effect that hormonal birth control can have. And again, this is for hormonal methods because those are the ones that affect ovulation. As far as endometrial cancer, again, this is hormonal birth control is considered protective against endometrial cancer. So use for at least 12 months reduces the risk of developing endometrial cancer by 50%, with the greatest protective effect gained by use for more than 3 years. Another really important thing to consider, as I said earlier, this hormonal birth control can be used to treat endometrial intraepithelial neoplasia, which is a precancerous lesion. The Mirena IUD is actually considered almost essentially a cancer treatment because it can prevent cancer from forming, and it can prevent patients from undergoing a hysterectomy, meaning a removal of their uterus early on in their life, just by using the birth control, which I think is pretty spectacular. And then the last one I wanted to cover was cervical cancer, which was actually a discovery period for me. There's actually a twofold increase in cervical cancer risk after 10 years of use. There are a few caveats to this, including some other confounding variables, meaning issues or other factors that are involved in the statistics. So contraceptive users are more likely to have more sexual partners. They're also more likely to have more HPV testing and more pap smears. They're seeing gynecologists more often because they're getting refills for their birth control and they're appropriately getting screened. And they sometimes screen positive for pap smears and potentially even cervical cancer. So that is something to consider. However, there are actually many studies that show an increased risk of cervical cancer with hormonal contraceptive use, even despite those confounding variables. However, the concern here again is that these are considered retrospective. So again, to cover that, basically it means that they're looking at a pool of population or a population pool that already had cervical cancer and they had been treated with birth control earlier in their lives. There is no prospective trial, meaning like a trial where a patient has received birth control and they continue to follow them for the rest of their lives until they essentially develop cervical cancer. That's the theory. That's the theory, at least. There is one review that I did see that was prospective that showed no consistent evidence of an increased risk. So it's something really important to consider as far as discussion with your provider. There are a few things we for sure know about cervical cancer. It is through and through caused by HPV. It is preventable by yearly screening, and there are vaccinations available for HPV called Gardasil. That can be something if you are someone who is high risk, meaning that you work in a high risk field such as obstetrics and gynecology, or if you are someone who partakes in or if you have several sexual partners, then the recommendation is that you can get the Gardasil vaccine up to 45 years of age. But it's just a conversation that you can have with your doctor. So that's extremely important to consider that there is an increased risk for cervical cancer. However, there are methods of preventing cervical cancer otherwise that can that still may allow you to continue with a hormonal contraceptive if that's something that is indicated for you. In addition, this is something that you may have seen floating around TikTok, Reels, that birth control, especially combined hormonal contraceptives, are considered a group 1 carcinogen per the International Agency for Research on Cancer. This is super important to know. So the group 1 classification essentially means that from all the studies that they have looked at, it is considered a known carcinogen in humans based on risk factors such as BRCA1, BRCA2, family history, and medical history. So the main caveat with this is that there have been studies that show that this has caused cancer in humans. However, there's usually some sort of other risk factor affiliated with that hormone. So other group 1 carcinogens to consider: tobacco products, solar radiation, as well as alcoholic beverages. And that is to say, yes, there have all been studies that show that tobacco is associated with as a known carcinogen, as has been seen to cause cancer. However, it's not a 100% causation. Same thing with solar radiation and alcoholic beverages. It's basically like dose dependent, meaning if you're continuing this for the rest of your life, if you're partaking in other habits, have certain family history, risk factors, etc., then again, this is a conversation that you have with your doctor regarding your individual risks. But super important to consider. The group 1 carcinogen, or the groups of carcinogens, are more of a classification from a scientific perspective and less of a way to kind of fearmonger a population. Alrighty. Next, true or false? Contraception protects against sexually transmitted infections.
For this, we had half and half almost, like 53% saying true, 47% saying false.
Yeah. And that's technically false, but also true. Not all contraception protects against sexually transmitted infection. Barrier contraception with male condoms can protect against sexually transmitted infections. However, routine testing is still indicated, especially for patients less than 25 with risk factors. Or if you are simply concerned that you may have an STI, you may ask your provider to test you. So extremely important. Barrier contraception is the only method that may protect against sexually transmitted infections, but that's only with perfect use, and testing is still recommended. Alrighty, contraception can cause weight gain.
We had 82% saying true and 18% saying false.
Yeah, so this is true. It depends on the method. Depo-Provera, which, as if you remember, is the injectable form of birth control, That is the most highly associated with weight gain amongst the hormonal birth control options, while the other hormonal contraceptives have not effectively been shown to affect weight. However, it is really important to consider progestins are considered an appetite stimulant. So if you are a patient who is interested in weight loss or are concerned about weight gain in general, that is something to consider and to speak about with your provider. Um, Again, the issue is in the dose. It's very dose dependent. If you are on a really high dose progestin, which is called Megace, which is a form of birth control, however, it's not often used for contraceptive methods. It's usually used for heavy menstrual bleeding. That is considered an appetite stimulant. It's actually used in cancer patients to help them with their weight gain. So that's a conversation to have with your provider. If that's a concern that you have, then there are other options available for you. There are non-hormonal options available. In addition, anything that's considered non-systemic, for example, the Mirena IUD is something that is not associated with weight gain because it's not in your bloodstream. It's simply effect that's down in your uterus. So it also is not affiliated with weight gain either. All right, so now we'll kind of transition over to some of the considerations to have in South Asian populations, specifically from a more patient perspective. So, number one, as I will continue to mention for the rest of my life, please, please, please advocate for yourself. Come armed with information. Your brain is your biggest tool and your armor that you have with your provider as far as what they can do for you. Understanding your health history is pertinent to having a fruitful conversation about contraception with your provider. Knowing if you have risk factors in your family, meaning breast cancer, ovarian cancer, uterine cancer, or any other concerns, those are very important to mention to your provider so that they can make the best choice for you. And then I did want to mention remembering your why, quote unquote, which is essentially what you wish to gain out of being on contraception, whether that is simply the contraceptive benefit of not being able to get pregnant effectively, or if it's something that's non-contraceptive, such as using it for PMS, endometriosis, PCOS, understanding what you're coming in for, and knowing that there is a method out there for you. However, it may involve a little bit of discussion with your doctor. And then, as always, there are concerns for religious as well as cultural ramifications when it comes to contraceptives. At the end of the day, it is considered a method of medical care and health care for yourself. So if it's a conversation that you wish to have with other family members, it's important to understand your boundaries and see where where they lay, and if you wish to hear other opinions, then that is something to consider as well. As far as the provider perspective, there are many things to consider. Of course, the recommendation is always for a thorough history and physical, just as much as a patient has to come with as much knowledge as they can regarding their own health history. It's our job to elicit that during a conversation too. Ensuring that we are watching out for any risk factors they may have, if they have a history of clots, if they have a history of heart disease, cancers. Those are really important to elucidate in a history and physical. In addition, maintaining cultural competency and understanding that this decision may be something that is collectivist, in that it may be something that is a discussion that a patient may have with their family member who's at bedside, with a friend, a loved one, family experiences, and kind of taking that into consideration, while also maintaining patient privacy. And to consider private counseling and discussions if you notice that a patient may be exhibiting body language of discomfort with maybe a family member who's in the room with them. It is always appropriate to ask if a family member can step out for a moment and to have a private conversation with the patient at the end of the day. Something else to consider that I will briefly go over after this as well as a resource is the CDC medical exclusion criteria, which is essentially a large chart that goes over any other pre-existing conditions a patient may have and their risk factor and their risk as far as health outcomes and different methods of birth control or contraception. So that is essentially like a plug and chug app, and it's also a chart that can be used to find the best option for a patient. In addition, appropriately counseling patients is always important, but especially in populations who have previously had gaps in care, and also ensuring informed consent. Managing expectations when it comes to contraception, ensuring that patients know exactly how to use it, as well as any adverse effects that they may experience. It is important to note that almost every method that I discussed today have some sort of adverse effect, usually affiliated with irregular bleeding, as well as potentially even having no bleeding at all, meaning amenorrhea, no periods. So it's important that patients understand that these are some of the effects that are associated with the medications, and to ensure that they have appropriate expectations as well. And then something that I personally recommend is a balance of evidence versus anecdote. Using evidence-based medicine is in a patient's best interest, of course. What I personally have found important as well as helpful for patients is personal anecdotes or patient stories that that are de-identified that may show that a method has been effective in the past. It ends up being a point of connection that you have with the patient yourself, as long as you're okay with like divulging that information, or it may present as something that may gear them towards wanting to try a certain method of birth control. For example, I'm very open with my patients about using a Mirena IUD as someone who has experience with it, and it is something that I kind of discuss within the realm of using the evidence. So I'll discuss the side effects associated with the birth control method and discuss maybe my personal experience with it. As far as those side effects are concerned. And I still mention that, I'm only one person, I'm not a sample size, but it's just something to consider. And sometimes they find that personal connection important as far as making their decision. All right, so these are some of the resources. As I had mentioned, this is the CDC's medical eligibility / exclusion criteria for contraceptive use. This is an app that providers can use. It's just called contraception. It's a very basic name. It's like I said before, it's essentially a plug and chug app, meaning you see what pre-existing condition a patient may have and what method of birth control may be best for them. Here you can kind of see the greens and the reds and the oranges as far as what's considered safe and what's considered unsafe. It's kind of a recommendation. So you'll see like a 1 with a bright green. It means that there's no real restriction for using that form of contraception. Whereas the bright red that you see here means that it likely is a health risk that is unacceptable and is something that patient likely should not use as far as their contraceptive method. But they list this for almost essentially every condition you can think of. It's very comprehensive and it's super effective as far as kind of to asking or showing patients what's the best option for them. In addition, this is something else that is available for patients. CDC.gov/contraception has an amazing graphic as well as information regarding birth control methods. So they go over every contraceptive method that's available. It's very evidence-based, it's comprehensive, and I find that it's really easy to read and follow along. In fact, I did use it for portions of this presentation, just because it's essentially what ChatGPT can do for you, but it's already there, essentially. In addition, womenshealth.gov also discusses birth control methods. They also have a great fact sheet available. Office on Women's Health also has several other patient materials, including like things for pregnancy, breastfeeding, other women's health conditions, HIV, STIs, menopause, hypertension, diabetes, what have you. They have a really good comprehensive guide. And for now, these have been excellent resources so far. Additionally, last resource, more so for the data nerds, Guttmacher Institute is a free web page. They cover many topics in reproductive justice nationally as well as globally. They do a lot of research. They also offer some good resources as far as contraceptive methods as well. They kind of do like that deep dive comprehensive thing that the CDC does as well. And they also talk about policy as well as changes in administration, which are great if you're a person who wants to stay in tune with what's happening in the news and see if there's any kind of legislation that's affecting contraceptive access too. So here are some of my references for the presentation, and then now I'm going to open it up to Q&A. I hope that was really helpful for everyone.
Could start recording. There we go. And I will briefly share my screen for our last slide. Let's see. There we go. All right, so this is just to let you all know, this is our SAPHA info for everyone or anyone who wants to learn more about SAPHA. This is our website, www.sapha.org, sapha.org. You can also reach out to us here, and here is our Instagram, SAPHA info. Thank you so much again, everybody, for attending. We really enjoyed having you all here. And of course, thank you, Dr. Sohni Pathan, for your wonderful presentation. I think all of us learned a lot. And, we loved having you answer our questions as well about everything that, many of us wondered growing up and were never told or, had our questions answered. So stay in tune and keep in touch with us for our next workshop or webinar. Yeah, hope to see you all again soon. Thank you.
Thank you. Thank you all so much. Take care.